Hey, now we start. All right. Announcement finalization. Exam will be 2 weeks from today, 29th. Same bad time, same bad station. That's a 1960s Batman TV series. And we will, there's going to be some stuff on joints. I'm starting to work on the exam. I anticipate there's going to be no more than 60 questions, so it'll be a little shorter than the last one. Same kind of format. I'll show you. I'll talk about some. The joint part's going to be very distinctly limited. And today, this is a lot of this is a lab lecture. There's things that you need to know some of this stuff depending on what you're doing with your lives, your career wise going forward. So a lot of it's terminology and understanding what goes on. And I mean, maybe it underscores the difference the way you talk about things in the classroom versus you talk about things in a clinical setting because it's different. You don't necessarily use the same expressions and things like that. And it's something I hope to be helpful for all of you with. That is today, the massive frame of today. And so we're picking up where we left off. If I can get my buttons here on this. Blue, don't mess it up. It should be shot. Come on. Thank you. There it is. Don't know how to work those things. So come on and we'll get situated and organized and go from there. So this is, you may remember when we left last time, the part that I take the greatest degree of issue with is when you have these folks doing PowerPoints. Maybe they're looking at it from an anatomical perspective, from a physiological perspective, from a clinical perspective. It's all, they don't know what they're talking about. The single most important factor, they have this totally, you say bass backwards. Okay, the single most important factor in stability of a joint is the shape of the joint. It's not the least, it's not a minor role, it's everything. So you can tell whether a joint is, you're going to see why the shoulder is inherently is as unstable as any joint there is versus the hip, which is as stable as any joint that there is, just from the anatomy of the bones. The socket itself tells you everything you have to know. Everything is about shape. Why we can tell that the articulation between the humerus by way of the trochlear surface and the trochlear notch on the ulna, all terms you learned about in bone from lab, inherently is extremely limited in range of motion. It only goes in one direction, more or less. So this is the kind of thing that's so important. Secondly, these don't have a limited role, they have a significant role. Ligaments, and understand the term ligament is used different ways. The context of ligaments here, when you're talking about bone and joints, this is what holds bone together. They're dense, regular connective tissue with a hint of elasticity. And what they do, if they don't limit, we dissected all the muscles off of a lower extremity, right from the hip down. And basically it stood on its own with just ligaments and bones. So when they're talking about muscle tone, most important, maybe I'll buy that for the shoulder. After that, they don't know what they're talking about. So I'm not going to ask. This is my view. Okay, from a lot of clinical experience, doing sport, looking at all of those types of things, taking care of people, and to understand. I don't. Maybe this is the anatomical view. I don't know. So I'm trying to give you some context. Why it's so important to look at the structure of these things. They tell the story. And the arch of the foot, that's the biggest, say it, Lou, bit of baloney you could ever hear. So all of these, if you want to scroll through this, it depends on what you do going forward. If you're going to be working in a field where this is something that's relevant in physical therapy and an orthopedic floor, you learn more and more about this. You may find it easy to go back and review these things just out of interest that are there. Which brings us to sort of classical stuff. And I mean, I know in classical anatomy and physiology, they talk about origin and insertion. They're really, the word I would use is passe. In modern, we look at what we call attachments. The notion, the whole idea of the, quote, relatively immovable bone versus the movable bone doesn't make any sense. If you're in the gym doing curls, okay, you're basically the less movable bone in that instance would be the humerus. The more movable would be the radius and ulna working in combination. Okay. Okay. Origin, insertion. If you're doing chin-ups, all different. These become the stable point, and you're pulling your whole body up by way of your biceps. Totally opposite. Different. Are you when you're stepping down, origin, insertion, when you're stepping down on a gas pedal? I'll buy that. Okay. But what happens if you go up on your tippy toes to reach something up on a top shelf? Okay. We know that the body work, it depends on the action that you're doing, what exactly they do. So that's why we use attachment. It's not, I'm not going to ask you about that, but you'll hear, to me, it's a better term to understand how they work. When we see what they're attached to, we can figure out how the muscle works, what it can't do, how that joint moves. All of that's really what you look at. So, I mean, that's much more of the modern approach. That's what I mean by passé, meaning it's somewhat in the past. But in classical anatomy, you would learn an origin and an insertion. You would learn, obviously, the name of the muscle. You would learn the blood supply. You would learn the nerve supply. That's classic med school anatomy. Absolutely. So I got that type of stuff. And you learn very quickly how there was a lot less application of that when you start seeing patients. More on that as we move along. So, and it moves, does it move toward the origin? Not all the time, obviously, but it moves. And we look at the motion occurring in planes, and it's not always in planes, and that's what we're coming to. So typically, when you think of movement in planes, the way you're going to see this definition. So again, this is a lab record, and everything is in reference to the anatomical position. So typically, it's moving in one plane. The classic example is flexion and extension. That's a sagittal plane motion. If it's moving in the frontal plane, you'll see the terms moving away. We call it abduction. Always use the letter. This will help you when you get on the floor if you're going in that direction. Or if we move it from back toward the midline, adduction. Because add and abduction sound a whole lot the same. Never want confusion in a clinical setting. You always want, you're going to hear down the road, you're going to hear when it gets to the nervous system, we're going to talk about an afferent nerve. Now emphasize the A, or an efferent, emphasize the E, because afferent and efferent, when you pronounce them quickly, sound the same. So you don't want to get confused. Afferent is an incoming signal sensory, or an incoming something. Efferent is an outgoing something. All of that's part of the nomenclature thing. And so that is frontal plane motion. It's not limited to that. It depends on the position, the body part, etc. And then you have transverse plane motion, and typically they'll say medial rotation and lateral rotation. You won't even hear those terms on a hospital. The orthopedic surgeon is examining a patient, they're going to go internal and external rotation. That's the criteria they use to determine, oh, we have a real limitation here, we may have to consider, doing an operation, inserting an artificial hip or whatever. Get the idea? That's kind of where I want you to understand a little bit in this lecture on, what you're learning in a classical anatomy laboratory or a classical anatomy classroom versus the real world, so to speak. And so those, when I saw flexion and extension, add and abduction, AD and abduction or rotation, those are motions in a plane. They call those axes. So a non-axial means it really doesn't do that. So think of the joints that are in your wrists and your ankles, the little intertarsal joints or intercarpal joints. Or think about those facets on the vertebrae, superior and inferior. The joints are relatively squared off, and all it does is like shifting like this. So you take two objects and they move a little bit here, a little bit there, a little bit there, but it's not really in a plane. So that's called gliding and sliding. But the beauty of all those motions is they add up. So, I mean, it's almost like you can take your wrist and do all of those neat things with it because it has the combination of motion. The ability to move your back, to twist it and turn it, is an accumulation of motion at multiple joints. So so that's the good news, it's somewhat additive or cumulative. The bad news is there's a whole lot of joints, there's a whole lot of articular surfaces. And as you'll learn, not today, but on Friday when we look at arthritis, the trouble is when they become arthritic, they're a big problem. When they're traumatized, they're basically remember the names of the bones? You had the long bones or short bones. blah, 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 that whole thing, irregular, flat. Short bones covered in cartilage all over. When they fracture, when they're damaged, they're highly prone to arthritis. When you hear about common, really severe inflammatory arthritis, which we'll talk about, like rheumatoid, small joints, hands and feet, wrists and ankles. So all of that's what I'm trying to frame it for you, because probably the one I want to talk to the most about is arthritis. We're just not going to get there today. So today we're saving the knee and we're saving arthritis for Friday. And yeah, once we conclude with that, that concludes all the material on the test. And if I'm in a positive mood, given what might happen tomorrow night at 8:15, but I digress, I'll consider recording a review. So we want to root for the visiting team, but that is a trap game. Thursday night games when you're on the road, never good. It's statistically. You see what the Giants did to the Eagles? They killed them. That's a Thursday night game when the Eagles were the visiting team. They look like they didn't play. They didn't look like they were the Super Bowl champions last year. They're not as good this year. But I digress. Moving on. So if it moves in one plane, it's like pure flexion and extension. We only see that in a limited amount. If it moves in, and most of them move in more than one plane. For an index finger, okay, it can flex and extend, but it also, and this is at the metacarpal phalangeal joint, it can AD duct and AB duct. When you put them all together, it almost looks like it's tracing a circle, but it's not. It's just subtly shifting. It's not. It doesn't have the capacity to rotate. That would be so. This would be, rather than uniaxial, this is biaxial, meaning you can move and increase what we call degree of freedom. And if you have multiaxial, there's only two joints that do that. That's the hip and the shoulder. They are by definition ball and socket joints. And what makes them ball and socket is if you stabilize them, whether it's your big toe or let's say your index finger, you can trace a circle. It's called circumduction. So effectively, it's conical motion. And I don't have to shift anything. I can go through. It's a lot easier. It's a lot more vivid, more clear when we do this, as opposed to the hip, which has limited amount of motion available. So this is what we look at. We're looking at angular motions, we're looking at rotation, and we're looking at what we call sliding and gliding. And this is examples, and you will see this. This leads into something that you will likely see on the test. That will be effectively a Stein's modified matching. You know, use once, use twice, or not at all. You know, don't you love those? It's almost like the A and B, could be C. Haley's comet is coming through, might be D. I know. I'm not nice. So gliding and sliding movement, flat against flat, more or less, is what those small bones are. Okay, they slip and slide over one another, intercarpal, intertarsal, and superior and inferior articular processes of the vertebrae. Vertebrae are really the oddball, that so-called irregular joint. So even though these are by definition synovial joints, okay, the motion is not classic, but they are true joints that move, and therefore they have a joint cavity and there's synovium around. So they're just showing you these, for example. And again, I emphasize to you, it's a big problem, particularly as folks get older and they fall. How do you brace yourself for a fall? You put so they get a lot of fractures. And normally it would be just in the distal radius, something called a Colles fracture, which is maybe a little easier to deal with. But when if they don't get their hands down, I mean, these start to go. It's very, very difficult. Because when people use that ability to use their hands, very significant. Do you guys know what occupational therapists do? You do? What do they do? Excellent. It's got a great, here's an important thing, very, very well done. ADL, activities of daily living. And we'll talk about this again a little bit when we talk about arthritis. ADL, activities, going to the bathroom, washing your hair, taking a shower, getting dressed. Okay, just getting ready for work. You and I don't give it a single thought, hopefully. Any disease impacts your ADLs, your activities of daily living, is a problem. So, what effectively occupational therapy, they're highly schooled, in particularly in upper extremity anatomy and hands and all those things, because typically that's what you're working with. You're trying to re-educate patients so they be able to use those things so they can pick up a hairbrush, they can pick up a toothbrush, bar of soap, and then moreover, even if they have to get it, it's when you have something that impacts your activities of daily living, that's a big deal. I mean, I saw the deterioration in my own mom, who was driving a car from Rochester, New York to northern New Jersey with one stop when she was 86 years old. And then she took a fall one time when she was down there, ended up breaking her wrist, and ended up then all of a sudden we started to see the problem surface. And eventually she had another fall because that is almost like started, the spiral was there. And the next thing you know, all of a sudden, her ability to do the ADLs really began to be limited. And by age 90, Alzheimer's was there. So I've seen that. So that's what occupational therapists are charge is. But really what they learn a lot about. It's so important. So that's the type of thing, if you're going to be in a clinical setting, you want to be watchful of those. And it's significant when you ask those questions. Do you have any trouble getting dressed or this? It's so significant. So significant. And that's what really, and it's a great context. Very good. Angular, increase or decrease. Most of the time there's sagittal plane, flexion and extension. You're going to see the elbow, because how it's constructed at the trochlear prominence or the trochlear surface of the humerus and the trochlear notch of the ulna, really creates almost the perfect hinge. Hinges are interesting in that regard. And so, and as you'll see, when you have a lot of those, you're going to see flexion and extension. Now, some of them are designed with all those wonderful little joints that are there. Theoretically, you could flex and you can extend, but we can hyperextend. You can flex, you can extend, but you can hyperextend. Some joints are designed to go past the return, that 90-degree point. But when it's an elbow or a knee, and typically what prevents them from when they hyperextend, now you're ending with an injury. Something's got to give. Either you're going to damage soft tissue or you're going to fracture a bone, period. Most of the time, anatomically, it's bone-to-bone contact that limits that. We look for things that are bony stops. Sometimes to increase range of motion, you have to go in and almost shave a little depression for bone to allow it to have a greater degree of excursion. So they'll show, and this PowerPoint has, any PowerPoint will have these sequences, any textbook will show you. They just have different folks who are modeling things anatomically. So it just gives you an idea of the same stuff I was trying to, et cetera, all those things. Pretty straightforward. AB and AD duction. Frontal plane, and again, all about the anatomical position that's there. And circumduction involves all of these, but again, that Conan space. So they're just showing you where this is. So you can hyperadduct like this. You can cross your legs, you can cross your arms. It's not necessarily inherent stability, but you have the capability of doing it. So, it depends on what, again, that's the difference between something, how often do we do this? Unless we're doing something just to make a point. And then rotation on its long axis, that's transverse plane. And again, clinically, you're more, you're not worried about the anatomical position so much. You want to know if it's going in or going out. So that's where orthopedics will always say internal and external. They've been trained that way. And again, there's only two joints that do that exclusively, called pivoting joints. And you're going to see, and you already know what the two of them are. Okay, you have C1 and C2. You can see it's a pivoting joint. That's how you do your head, like this. So you have the atlas and the axis. So the the axial atlanto joint. Okay, you remember that guy on the axis? So here's C1 is the ring of bone. C2 is really the body of the ring of bone. And what happens at dens is kind of the body. There's a joint that forms there, a synovial, a moving joint, and it pivots around that joint. The other one, radial head and the radial notch. Only two of those. That's one of these questions, and I'll show you the answer key, and you can You can discern the question. You don't have to thank me, it goes with the service. This time, lab's over by this afternoon or this evening, and from that point on, you're studying the lecture stuff. And these are different motions. So, again, hold your elbow at 90 degrees. That's that rotational component around where the radius and ulna, involving the radial head, okay, in the radial notch, involving the looseness of the interosseous membrane, allows you to pronate, palms down, supinate. We use the terms anatomically. In an operating room, patients start in the supine position on their back. If we have to move them, we move them after they're asleep, assuming we're using a general anesthetic. Because what happens is we can intubate them easily there. Now you have an airway, because if you move them on their side or on their tummy, it's easy to lose the airway. So if you're going into anesthesia, you'll see it. And the way you do an operative report, you say the patient was placed in a supine position in the operating room following induction and maintenance of general anesthesia. The anesthetist or the anesthesiologist intubated the patient, and then we were able to rotate the patient 90 degrees up on their right hip, exposing the right hip, blah, blah, blah. So it starts. So you record that information. See, I did used to do this stuff. It was a long time ago. But I did used to do that stuff. And so you'll see that. And so there's not the only, now you see it even in the foot. When you try to flatten out your foot, we have a flat foot, it's called pronated foot. When you have a high arch foot, we call it supine. When you try to arch up your foot, it's supinated. So different areas that have unusual construction may have different names that are used differently. When you step on the gas, we used to call that extension. Now we call it plantar flexion, flexion toward the bottom. When you bring your toes toward your nose, we used to call that flexion. Now we call it dorsiflexion. So you may or may not see those terms. Remember the one I commented on before, inversion. Remember Monday we were talking about if your sole of your foot goes toward the medial, that's the most common way we sprain an ankle. An inversion sprain, if it goes the other way, the sole of your foot facing outward, you can sprain that way, but usually that one involves broken bones. Eversion fractures are not good news. And specific motions like protraction and retraction or grinding motions of your jaw are specific to that particular jaw. Same thing with the jaw. We talk about elevation and depression. The only one that's really active is closing. When you begin to lifting it, opening your jaw, elevating it or closing it. Okay, effectively, that's where the muscles are used. Gravity opens it up. And inevitably, in any animal that you encounter, including us, the act of closing is immensely stronger than opening. The muscles that close the jaw. Think of what they do with an alligator when one's gotten loose and they're able to capture it and return it to wherever its proper environment is. First thing they do is you get your hands over that. That's the part that's going to hurt you. Because that jaw, when they clamp, big trouble. And there's unusual movements like opposition of the limb. And that has to do with the construction of the joint. So elevating and depressing, there's the opposition, basically being able to do that. And they have all of these different motions that you can review. So here would be the answer key. I would use all of these save one, because they've got 6, I'm only allowed to use 5. And so it would either be a plane joint, a hinge joint, pivot, condylar, saddle, ball and socket, one of them won't be there. And effectively, I would have that, A, B, C, D, and E, and then I would have name the joint, and you'd have to match them. You just have to figure out which one it is. They're all looking at me like, it's not that hard. Why? There's only one saddle joint. There's only 2 pivoting joints. There aren't a whole lot of perfect hinge joints, and the plane joints are intertarsal, intercarpal, and superior and inferior articular facets in the vertebrae. Ah! Remember exceptions. There's a ton of condylar joints. There's only 2 ball and socket joints, the hip and the shoulder. You got it? This ain't hard. So here you go. So they're all synovial joints. This is a classic classification, to borrow the phrase, and they're non-axial motions, and again, the accumulation of all of them. So all those neat little joints. No, you don't have to remember the bone names for me. Did you have to learn all 8 names for the bones? Good. You remember any of them? Yeah. Yeah, the carpal bones. Scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, and hamate. Hamate's got the hamulus. And here you have these two. Here you can see a classic example of the hinge joint for uniaxial motion. The elbow is the classic. The other ones are interphalangeal joints on the fingers and on the toes. Again, metatarsophalangeal joints or metacarpophalangeal joints are different. Interphalangeals are proximal and distal. Interphalangeal joints, same fingers and toes. They're very much like this. What makes this the perfect hinge, this is called a trochlear. Remember, this is the trochlear surface, and this is the trochlear notch. A trochlea is a pulley. So a pulley has that indentation here. And now notice the marriage. You have basically this prominence, this sort of almost identical surface going in the opposite direction. It doesn't allow, literally and figuratively, wiggle room. If it wiggled, you could adduct and abduct. Here, it's a pure hinge. The other joint is a supportive joint, where you get the capitulum, and the other portion of the head of the radius doesn't do a whole lot. If anything, it's a little bit more useful in the rotational component than anything else. The big player in the joint here is this. Okay, so that's where that's a hinge joint. And so, and again, uniaxial motion. There's only 2 pivoting joints: the radial head in the radial notch, and the other one I told you about, C1 and C2, the atlas and the axis, and effectively the atlas rotating around the dens. And if you look, you remember looking anatomically, there was a little notch in the atlas that, and the dens was covered in cartilage surrounding this way. And those are the only 2 pivoting joints. There's a ton of condylar joints. What makes them condylar is you have a convex and a concave surface. And that allows almost exclusively flexion and extension, and then AD and abduction. The knee is slightly different. We'll look at the knee next time, but what happens is, by putting in those menisci, by adding the fibrocartilaginous discs, it still basically facilitates flexion and extension, but also rotation. You bear weight, you take a step and move forward. Just watch somebody see when they're walking, when they're running. What happens is when the foot comes down, you'll see the ability that basically has an unlocking ability that allows the femur to rotate internally. And that, all that is about shock absorption. When somebody walks stiff-legged like this, they got an injury or something like that, then the shock is neutral. So that's where the mechanics of this come in. We have a lot of students who take the same class. Maybe there's some in here now who are biomedical engineers. This is the kind of stuff where they're understanding the functional nature of the anatomy assists them in their endeavors. So it's called a biaxial motion. And then there's only one of these. You all oppose their thumb. It's a saddle. So the distal aspect of the trapezium articulates with the base of the first metacarpal. It's unique. There's only one of them. 2, because they're bilateral, obviously. So you have a saddle-shaped surface on the trapezium, and you have the sort of the mated surface, the reverse of the saddle, and that allows this almost circumduction, but not quite. It doesn't have the rotational component per se, but it has a remarkable amount flexion and extension and AB and adduction as part of it. Remarkable amount that allows the opposition of your thumb, which is a very interesting, it's our advantage. Why thumbs are so important. Why when we have fracture, and again, elderly folks, this is the kind of thing you really look for those. You'll see when we have to cast a fracture or immobilize a fracture, the thumb's almost separate. So we put a cast on. Basically, it's called neutral position. So you hold your hands like this and turn them upright. And that typically would be a wrist cast, but the thumb we would hold an extension like that and make sure that's incorporated. So these are all the little tidbits you'll see. Okay. And then there's obviously there's variations based on the condition that's involved, but it underscores why these little bones are such a pain in the neck. I can't tell you how many athletic careers have been ruined by this. In the foot, do you remember the navicular bone in the foot? Yeah, it's the third largest. You have the calcaneus and the talus, and then medially you have the navicular, sort of along that medial aspect. He died recently. He might have been the most athletic big man in basketball we've ever seen up until maybe most recently, in Bill Walton. He took over for Kareem Abdul-Jabbar. He replaced him when he graduated from UCLA, which won like eight or 10 NCAA championships in a row. The player stayed for 4 years. Freshman didn't play. Unbelievable. In his second year, his Portland team won the NBA championship. He fractured that bone. It never healed properly. I knew some of the doctors who tried to work on him. He couldn't. It was just so painful. He finally got it a little bit under control. He came back about 9 years later, was the best sixth man in the league playing for the Boston Celtics. They won the championship in '86. And then he went into broadcasting because finally it just gave way. But I mean, he had the most, I forget what he was, like 17 for 18 or 15 for 16 in the NCAA championship. Then it wasn't Purdue. Might have been against Jackson. I'm just losing my memory. I'll remember. She's just tremendous athletes, and that ended his career, very, very much so. And then over time, he became a very, very fascinating broadcaster for both the NBA and the NCAA. His son actually managed the Lakers maybe 10, 15 years ago. He was a pretty decent ball player himself. And then lastly, ball and socket joints. There's only two. It's pretty easy. And so basically that defines it. And we're going to look into it. By definition, they're multi-axial. So we're going to look at a couple of specific joints and we'll get through. Oops, I don't need that. Sorry. And this is, like I said, we won't get to the knee part of it. The first one, the most frequently dislocated joint in the body, temporomandibular joint. Okay, so these are the ones we explore. We'll look at these because the shoulder is interesting. The jaw and the elbow are relatively quick, as are the hip. The one that takes the most time for now, and where the rest of our time will be the shoulder. This is a modified hinge. What modifies it that makes it such a pain in the neck, and people have temporomandibular joint dysfunction, has to do with an extra piece of cartilage. Remember I told you last time we met that what allows this remarkable degree of mobility, and the only place where your upper extremity, the appendicular skeleton attached to the axial skeleton, is one joint, the sternoclavicular joint. It's got a little extra arthritic pad. That one, for some reason, doesn't get hurt too often. This one does. So it allows your jaw to shift side to side, to protract and to retract, okay, has to do with this articular cartilage. Effectively, once you start putting cartilage, structures inside of joints, there's more stuff to go wrong. You'll see that in the shoulder. Okay, simple joints typically are resistant to problems. The more complicated they are, the more severe and significant the problems are. So you'll see this. But the other thing is inherently unstable because it only has a strong ligament on the outside, called the lateral ligament. So it's hinged in the sense it moves in the sagittal plane, and it does have that side-to-side ability. Yes, most easily dislocated. It's complicated by your bite. It's complicated by trauma. All of those things. But a lot of people have temporomandibular joint dysfunction. Most of it involves bite and jaw usage. And there's a lot of, you undoubtedly know somebody who has this. Sometimes this problem presents itself as sleep apnea, and a lot of people having to wear devices around them or a plate. I know my wife, she doesn't like wearing it every so often. That'll act up. She'd have a bite plate that she used to have to wear when she slept. Those kinds of things. This is the lateral ligament. That's the big power. And inside of it, this is a piece of articular disc. Very much like the disc, the menisci in the knee. That inherently creates a problem. That's there. So it's the most common because the socket anatomically is very shallow compared to, and you'll see the same thing with the shoulder, anteriorly, and it's very difficult to push back in. You have to know what you're doing. People, be very careful that people are trying to push things back in. We see it, you'll see it in a football game on the sideline, but generally somebody knows what their trainer or a team physician knows what they're doing. Something that you don't want to do unless you know what the heck you're doing. All of these things are associated with it. Teeth, previous trauma, occlusion of the teeth, okay, bite plate, and really to put it back in, you're looking at typically some type of muscle relaxer that has to be administered. We used to use injections of Valium either intravenously or intramuscularly that would relax people enough that you could, they were, because it's a central skeletal muscle relaxer. It also made them pretty sleepy. Big statement. The whole idea of the upper extremity and the shoulder is mobility. The whole idea of the lower extremity is stability. They're opposites. If you want more stability, you're going to sacrifice mobility. You want more mobility, you're going to sacrifice stability. It's just the way it works. You can't have it both ways. So the motion is designed. We interact with the world by our upper extremity because of the design. They call this a ball and socket. It's a ball and socket only because anatomically, again, it can circumduct. It has an extraordinarily large head on a relatively at best a socket. You remember looking at the glenoid fossa on the scapula? It's flat. The only thing that gives it some degree of socket, if you want to call it that, is what's called the labrum, a fibrocartilaginous lip. We have the same assembly in the hip, but you saw the acetabulum in the hip, contributed by all three bones, the ilium, the ischium, and the pubis. If your mom said, show me a ball and socket, you would show them the hip. If you show them the shoulder, they go, what the heck is that? And they have a wonderful analogy for it. It's like a golf ball on a tee. I have a lot of experience with that because I don't hit them very far. So I used to be okay. Okay. It has a very anatomically a weak capsule. This is the one exception. If you're talking about something that was held together by muscles and tendons, that's the shoulder. I'm not going to see, if I were in lab, you'd have to know all the names of the muscles of the rotator cuff. Basically, anatomically, it's much more stable superiorly with the bony overhang of the acromion clavicular apparatus, and posteriorly because of the spine of the scapula and those wonderful fossa, infraspinatus, and the three muscles posteriorly, supraspinatus, infraspinatus, teres minor to a very lesser extent, and only one anteriorly, subscapularis. You probably learned those. I would have had you know all four muscles. What makes them rotator cuff is they insert here, somewhere on the head of the humerus. Pectoralis major inserts on the upper portion of the shaft. That helps stabilize. So deltoid, okay, which inserts on that deltoid tuberosity and comes from the spine of the scapula. That helps stabilize it. Muscles and tendons are the big players in that. So here you can see it. There's not much of the way of a socket that's there. The labrum helps it, still 1/3. There's a lot of ligaments. The ligaments play a role, but certainly the muscles and the tendons that surround it play a significant. These are all has a number of bursal sacs that are there. Bursitis is very common. This again is the super stabilizer, that long head of the biceps. The short head goes to the coracoid process over there. So it's reliant on these structures where other joints are not. And you can see that from the illustration there. So the super stabilizer, the four muscles, I'm not going to ask you about that. So that's, if you were asked about it, were you asked about those things in the lab? Okay. That's where they belong. Beautiful cartilage that you can see there. Dislocation to shoulder are common. They're hard to put back in. You can see typically traumatic in nature. Arm tackles and things like that. Sport, we see it a lot. You see it a lot. Unfortunately, you see it a lot when people are fighting. See that? I told the other class when I was a resident, we had the city prison contract in Philadelphia. And we used to, hey, the prisoners had a softball game. We got some people to bring down for you. Oh, my goodness. And there was a big fight in the prison yard. Some extraordinary trouble. So as you can see, there's a comment there. Blows to the top and back of the shoulder. So if you end up treating an inpatient, incarcerated population, it's also very interesting. So I think you can see the muscles that are there. We're not going to have to go over. There's the deltoid, pectoralis major, biceps brachii is there. You can see it. The elbow, basically, it's secured because of the bony anatomy that's there. The ligaments that you hear about for pitchers in baseball, the one that has to be replaced, named after a pitcher who's around for 20 years, Tommy John. Tommy John surgery involves the ulnar collateral ligament. Now we replace it differently. We used to graft it. Now they're using a sort of a bioengineered kind of tethering device that holds it and gives it a little bit more mobility, but secures it. That's more common. Annular means around. And so the annular ligament is the ligament, does not necessarily involve here. That's the secure nature. You can see a bursal sac there. The annular ligament secures the head of the radius into the radial notch on the ulnar. The collateral ligaments, it's not one distinct ligament. Very often, collateral ligaments are in maybe 2 or 3 sections, as you will see. Here you can look on the ulnar side. So you have it going along from that medial epicondyle onto the ulna, but you can see branches going downwards, additional branches. So it's almost like a triangular type of, it's there. And then lastly for us today is the ball. And this is a true ball and socket joint. Anatomically, it's highly stable. The capsule is very strong. The ligaments are very strong. And the anatomy of the head is so remarkable. So, and it has a labrum. I told the other, when you hear one of these pulled out of the joint at surgery, when we're doing a hip replacement, I mean, it makes a sound that it's like a champagne cork popping. It's just, I mean, you would just, if you heard it, you look over and see it, and I mean, it's not easy. Orthopedic surgeons are generally good sized. I mean, because you're putting some force in. I mean, the surgeons I work with, this guy was a good 250. He was a football player in college. I mean, pulling this thing out, a lot of strength. So, I mean, when you operate on bones, and I did a lot, you need to be fairly physical. And so this is what it looks like. That head, that ligament is not structural. That contains the blood supply. That's beautiful white cartilage. You can see the size of the head. You remember the way the acetabulum looked. I mean, it's a deep socket. All of these ligaments help to secure it. Okay. Greatest stability, deep ball and socket. I couldn't have said it any better. Ligaments both posteriorly and anteriorly play a pivotal role. It doesn't matter which way you're looking, the anterior view here or the posterior view here. So it really is held wonderfully. And we'll stop it here because the knee joint, we're going to dedicate knee joint and arthritis to Friday. Thank you.